Okay, well, my name is Ann Berg. I've been working with the SCN2A Families Foundation for a few years now, quite happily. And today we'd like to tell you about the results of your SCN2A clinical trials readiness study. I want to start by thanking Leah and the SCN2A Families Foundation for their incredible support throughout this journey, and all of you who took part in this journey with us. And I'll introduce our team in a little bit. Just a reminder why we're doing this study in the first place. SCN2A related disorders, as you well know, are more than just seizures. They involve severe to profound impairments in neuromuscular, autonomic, cognitive, communication, sleep, behavior, GI, visual function, you name it. Across the board, we find difficulties. We're now in the age of precision medicine, and precision medicine means we're not just looking for another seizure drug, another Band-Aid to fix a symptom, but we're really hoping for medicines that will address the disease process and in some way improve the overall condition of the person, move that person more towards an optimal state of health. In order to do that, though, we have to show people get better. And that raises a really critical question. Which other outcomes should we measure? And really critically, how do we measure them? These are from your data, the SCN2A Family Foundation data from the Simon Searchlight project, in which a large number of families took part. And we analyzed these data a few years ago, and we looked at the Vineland. Remember the Vineland? You had to fill that out over and over again, and I know you curse it day and night, but it's a really important measure, and we're going to tell you more about the Vineland in a little bit. But you filled out the Vineland, and the average scores in the SRD group, the SCN2A related disorders group, was in the mid-50s. This is a score that is 3 standard deviations below the population mean. And for anyone not familiar with those terms, a tiny, tiny bit of statistics, a lot of things in the general population follow this mathematical construct called a normal distribution. Things like intelligence, weight, behavioral factors, a whole bunch of things. And it makes it very easy for describing what's going on in a population. So a normal distribution is characterized by its mean. We often use Greek letters, so don't be put off by that. So there's an average, and then people sort of fall, half the people fall above the average and half below, very few are exactly average, and there's variation. And that variation is captured by something we call the standard deviation. And the standard deviation in a normal population is such that about 68% are plus or minus 1 standard deviation of the mean, 95.4% plus or minus 2. And if we go out to 3 standard deviations from the mean, we have almost everyone, 99.7% of the population. In a measure such as the Vineland, with scores down here, 3 standard deviation below the mean, that means your average is all the way down here where there are only a few people. And it means that it's very, very hard to tell what's going on in that group using a measure like this, which is great for saying someone's average, high average, above average. It's not so great for distinguishing what's going on at -3 standard deviations of the mean. In the report I sent out for you, we talked a little bit about that it was like having a baby mouse, and you love this baby mouse and you want to see how this baby mouse grows from the day you get him till he becomes an adult. So you put him on the bathroom scale, and the bathroom scale registers exactly 0. And then you measure him every day, and a month later, you can tell this mouse has gotten bigger. There's more heft, he's bigger, he weighs a bit more in your hand, but the scale is still telling you 0. And that's the problem with so many of the measures that we have right now. You can tell your child is growing, is changing, is developing, but our measures just don't pick up on it. For the clinical trials readiness study, what we did was look at a large number of promising measures, and you know just how large a number they were because you filled them out. Thank you. But these were measures often designed for younger infants and children. And we also, very importantly, have looked at other ways to use standard measures like the Vineland. Instead of the Vineland 2, we used the Vineland 3, and Dr. Anderson will talk a bit about that. We used it because it's really well known to the FDA, so we think they're much more likely to accept it if we propose it for a trial. It's very well respected, and it's a very well done instrument. And I'm not advancing. There are new ways that we can score the Vineland. They're called growth scale values, and you'll hear about that some more as we go along. But just to give you a rough idea, they're absolute amounts, they're not relative to typical same age peers. So usually when we look at the Vineland, we say, well, your child is really, really low compared to other children his age. We don't care about that. We just want to know how your child is doing. And what these growth scale measures allow us to do is to take that range down here and now use a different tool for measuring it. It's just like putting your mouse on a different scale that's now measuring in grams or ounces instead of in pounds. We can start to see how much he weighed initially, and we can watch him grow. I'm delighted to have with all of us today, our team. It's just been such a pleasure working with them. Real quickly, I'll introduce Dr. Erica Anderson, who is a pediatric clinical psychologist, and she's really run the Vineland section of this project. With us also, we have Lindsay Evans, Ari Kaiser, Catherine Paltel, and Amanda Nilly, and most of you have met at one or two or maybe all four of them over the course of the study. They are all super clinicians, all have masters in psychology. They're finishing their PhDs, going on to amazing internships, and those of you who have met them know just how wonderful they are. I'm also really delighted to have Dr. Aaron Kott, who is a psychometrician. He is the guy who understands all these numbers and can make sense of them. And Aaron actually trained at the place where some of the measures that are often spoken about, like the aberrant behavior checklist, come from. He's a specialist in this area, and it's great to have him on the team. And I don't know how I could ever begin to do these studies without Jerry Nesbitt, who's here. Thank you so much, Jerry, who's in Dublin right now. It's a bit late for him, but Jerry has made this study flow. And those of you who have been on our website, I know you appreciate it because this is Jerry's work. So with that, I'm going to turn this over to Dr. Erica Anderson to talk to you a bit more about the Vineland Adaptive Behavior Scales.
Thank you, Anne. I am delighted to be here. Thank you so much for welcoming me into this community. I've learned so much, and I feel like I have grown so much in the course of this study that I could be measured on the scale, I think, and how much the big scale in terms of how much I feel I've grown throughout this study and learned. And so I've really enjoyed it. I want to talk a little bit, I'm going to briefly talk about the Vineland, not the statistics. I'm going to leave that to others. That's not my area. Is more about developmental and neuropsychological assessments and engaging families in that process and training folks in doing those assessments in a way that is responsible, reliable, compassionate, and respectful. So that's what I think our team has done a beautiful job, and I hope that folks feel that they've been in good hands with our wonderful team. But the purpose of the Vineland, I know that people, as Anne said, people have done the Vineland so many times, and so most of you probably know this, but I want to talk a little just to kind of make sure we have the same foundation here, is that it measures adaptive functioning. So skills or behaviors that one needs to take care of themselves and to engage with others. And so not really necessarily what the person is capable of doing. Of course, that's important. You can't perform adaptive skills without the capacity, but it's more about what they do. So not what they can do, but really more about what one does do. And Lindsay always uses great example, shared the example with us that I think we all use now when we're introducing the Vineland to folks. It's like, I'm very capable of making my bed, right? I know how to do it. I can do it well but I don't do it every single morning, right? And so if you're measuring my adaptive behavior to kind of take care of keep my bedroom picked up and neat and clean and ready for the day. It's not always there, right? It's so I have the capacity, I just don't always perform the behavior. And it measures functioning in 4 domains and 11 subdomains. And we look at communication, which looks at expressive communication. So what one does to communicate with others, receptive, how they understand what is being communicated to them. And then the written, which is basically the beginnings of kind of academic skills functioning. Daily living, looking at personal skills such as taking care of oneself, feeding oneself, personal hygiene, domestic, being able to kind of stay safe in your home and kind of function independently in the house. And then community is more about functioning sort of more, independently out in the community. Socialization, so interpersonal skills, how I relate to others, how they, play in leisure, how I kind of engage in activities that, that feel good, right, and that are enjoyable, and coping, how I would deal with emotional upset, changes in routine, things, what happens when I'm upset, how do I manage my behavior and my feelings, and then motor skills, which are both the fine, so the small hand movements, small arm movements, and then the gross, the large, being able to walk and climb and jump, and so that's what the Vineland measures. You can next slide, Anne, if you don't mind. I don't know.
Yeah, sorry, I'm just having a little trouble getting it moving.
That's okay. I just didn't know if I don't think I had control. So so the next thing that we're going to talk about, okay. Oh, next, I think you missed one. Yeah, there we go. So what did we do in this project? We felt it was very, very, last one Anne talked about, the Vineland is a very important instrument in this kind of research. As she said, the FDA really kind of looks to it. We wanted to make sure that we were really doing it well, and so this involves training, and more training, right? The interviewers participated in initial training sessions with me where we went through all the different questions. We did some practice interviewing, talked about what each question is actually trying to get at, because you can make, those of you who filled out the surveys, it's like, well, what do they mean by this? Do they mean this, or does this question mean that? Making sure that we're all reading the questions in the same way, helping families understand what the question is asking, and then how to score each question correctly, so we're all consistently scoring it in the same way. The interviewers did some practice interviews, and I listened to those and scored them separately, and we checked on that, provided a lot of feedback on that. And then I actually listened to, so I got to know some of your families, some of you guys, without being able to see you, but by listening to the interviews. I listened to 20% of all the interviews that were done and provided feedback to our team. And we met weekly to discuss those interviews and correct any, we call it drift. Somebody starts to go off, they start, interpreting a question slightly differently and asking it in a way that's not intended. So we keep everybody kind of, in the same lane, answer any questions, talk about some, complicated things that kept coming up. And that ensures the accuracy of, there we go. Oh, there we go. Next one. That's fine. Ensures consistency across interviewers. What I wanted to mention one other thing today, and then I'm going to turn it over to the team, the interview team. In terms of interpreting research results, I know we sent out, or folks had access to their reports if they were wanting to take a look at it. I just want to note that it's really essential to note that these results are intended for research purposes. They're not intended to be in replacement of a clinical report. They're not intended for diagnostic purposes regarding any one individual. They don't provide a comprehensive picture of your child's behavior and abilities. They can provide one window into it. And then, not that it's not accurate, we had an amazing team, it's that it's just not contextualized. We're not looking at other factors, like at the time of the interview, we're not seeing, any recent history of seizures or any other medical complications, even though we gather that information, but that doesn't factor into the actual results of of the Vineland. We don't look at things like recent stressors in the family or trauma that can very much impact one's adaptive functioning, no matter who you are, right? If I have a recent trauma, I may have some regression in my adaptive functioning. I might stop, taking a shower every day if I'm feeling stressed and depressed. And I may stop, taking care of myself in the same way that I'm capable of. So it doesn't necessarily provide a comprehensive picture of what's going on, or skills that might be just on the verge of, you just know your child's about to be able to do that, but we can't score that until they're actually doing it, our behaviors. So it's not meant to be comprehensive. I just want to note that. And, and of course, a thorough clinical evaluation would offer a more comprehensive and inclusive information about your child's adaptive functioning. So I think that's just really very important to note, that it's not the same as a clinical evaluation, although it does provide kind of a window into your child's adaptive functioning, but just a window. All right, thank you. And I'm going to turn this over to, I'm not sure who's next. Is that?
I am going to.
Yeah, there we go.
Casey.
Thank you.
There we go.
Casey's next. All right, our wonderful interviewer, Casey.
Yeah.
Go ahead,
Thank
take it away.
you, Drs. Berg and Dr. Anderson, for the wonderful overview. I'm just going to present briefly on some of the results we saw in the overall CTRS cohort. And then Lindsay is going to present on how to interpret your individual report, and Ari will talk a little bit more about some considerations and nuances of administering the Vineland in this unique population. So just to reorient you to the normal curve that Dr. Berg described at the beginning, the Vineland is on a distribution with an average of 100 and then a standard deviation of 15. So 68% of the general population falls within one standard deviation of that 100, and then 99% is falling between the 3 standard deviation range. And on the next slide,
Hang on a sec. I'm sorry, it's not advancing quite as much as I would like it to. Come on, little computer. There we go.
perfect.
Sorry.
No, you're fine. This next slide is a little bit of a different way to look at the distribution of scores in the general population and then the CTRS cohort. So on the left, you'll see a distribution of the general population, and the y-axis there is the Vineland standard composite score, again, with that mean of 100 and a standard deviation of 15. That blue, the large blue chunk at the bottom on that left, I don't have access to a cursor, otherwise I would use a cursor.
Right here.
Oh, perfect. Thank you, Dr. Berg.
Sure.
In the general population, less than 5% of individuals are scoring within that range. So that's about below an 80 on the Vineland, an 80 composite score. So only 0 to 5% of individuals in the general population are there. But if you look on the right at the CTRS,
Sorry.
no, you're fine. At the CTRS cohort, you'll see that 100% of the cohort is falling where only 0 to 5% of the general population is falling. What we call this is the floor effect that Dr. Berg talked about earlier, where everyone's really squished on the bottom of the distribution, which makes it really impossible to differentiate among individuals in this range, because everyone's smushed on the bottom there in the 0 to 5% range. So that's where the gross scale values come into play, because immediately looking here, this is a presentation or a distribution of the gross scale values in the cohort. You can see so much more variability immediately off the bat here. This presents the gross scale values for each domain on the Vineland that Dr. Anderson covered. And at the top, you can see the maximum possible gross scale value with that dash there. And then that blue line beneath it with the circles is the maximum possible gross scale value in the cohort. So that's the peak value. And then what's really nice to look at is the median, which is the dotted line with the squares. And that represents where half of the cohort falls above that score and half falls below that score. So immediately there's so much more variability and much fewer floor effects. And the domains that we do see the floors, which are the receptive domain excuse me,
No.
the written and domestic and community, that is where the age range starts at age 3. So it's understandable we'd be seeing floor effects there because those skills develop at a later age, and already this population's developing differently. So those are the main takeaways there. And then Lindsay's going to transition into talking about how to read your report and the scores that are on your report.
Yeah,
Great.
thank you. Yeah, so this might look familiar if you did access your report that we put on the study website, because these are the Vineland scores that we used and that we got from the interviews. So I'm just going to start from the left and kind of review scores to the right, and talk about what these mean. So as everyone has been talking about, we have standard scores, and standard scores have a mean of 100 and a standard deviation of 15. So we see here that for this individual in particular, we have very low standard scores compared to the general population. And just to reorient you, 20 is kind of the lowest standard score that we can get from the Vineland. And so we see a percentile rank that is from that standard score. So we see that those standard scores all fall below the first percentile. However, when we go further to the right, we do see that this individual was receiving some credit on some of the questions from the raw scores. So that's where, again, what we've all been kind of talking about, the growth scale values really come in handy, because these take a more granular approach compared to the standard scores, and will give us a lot more variability when using those scores that, and this variability is just not able to be picked up with the standard scores. So we're going to look at the next slide here. So this was also in the report that we gave, and this again shows the different growth scale values among the cohort for each domain. So what we see here is, for example, I'm going to pull out play and leisure because it has a nice variability. It shows that this individual for play and leisure had a score during the first baseline Vineland, and on the second and third Vinelands, we saw that score increase. And actually, we saw that score increase from, sorry, I really have to get close here, from the 51st to 75th percentile to almost the 90th to 100th percentile of range. And those percentiles refer to about how many, someone correct me if I'm wrong, how many of the individuals in the cohort land there. Is that
Yes.
correct?
Yes.
Okay, just wanted to make sure. So going back, so we can see this change over time in play and leisure, which we wouldn't be able to pick up using a standard score. We would likely see a standard score kind of stay at 20 or very low and below the first percentile, and we aren't getting enough information from that. So this is giving us more information and more critical information that can be used. I do want to highlight that the growth scale values should not be compared across domains or subscales, because they can't be compared, but you can compare within a domain. So within play and leisure, we can see that this individual score increased, but we wouldn't say that this individual has stronger skills in play and leisure compared to, say, personal.
Okay.
I'm sorry, there were some chats that came up that I don't want to miss.
Why?
Leah, did I answer that question for you?
You answered mine, and then Carla
Okay.
asked, why do you think the expressive measure got worse?
That's a good question. I do not know. I don't have any extra information from this individual other than just what the scores are here. It could be for a variety of different reasons. If anyone else wants to jump in, but I don't have really any other.
Yeah, that's something that we are going to have to be looking at carefully, because we do have information about what's happened medically and also seizure-wise, and there may be some factors there that play a role.
Yeah, that's sort of the contextualization as I was discussing, like what's happening there. Maybe there was some recent seizures activity in the last assessment that wasn't happening in the first, that's impacting expressive language particularly, and not so much the engaging in play or so yeah, so that's definitely something to be looking a little more carefully at.
Yeah, there are a lot of details in there that we still are working on. Should I go to the next one if my computer will let me?
Yeah, if there's no more questions on child reports, then yep. I think
I'm sorry, I'm having a really hard time getting it to advance. Go, there we go. All right.
Wonderful. So I am going to be talking about all kind of giving a taste of all the really interesting conversations we got to have each Thursday at our Vineland review meeting. And Dr. Berg would always come on to this meeting saying, like, this is my favorite meeting of the week, because we really did get to think through some really challenging and important questions that came up the previous week during parent interviews. So if you were a parent who got to speak with us multiple times over the past year, you probably at some point during the interview said something along the lines of like, oh, that's a really hard question to answer for my kid. It doesn't exactly apply because of this, this, and this. And we would probably respond by circling the question and say, thank you for saying that. I'm actually not sure how we'd score it. I'm going to bring it back to the meeting. So every single measure has its unique strengths and limitations. And then when you're applying that measure to new populations that haven't been really studied using that measure, such as the Vineland and SCN2A kids, you rub up against those unique challenges and considerations very often. So that is really what was, to me, one of the most rewarding parts of this study and being a part of this and speaking to all of you, was trying to think through how we can apply these very specific questions, getting at a very specific skill with kids who have learned to compensate for certain skill challenges or deficits by using other skills that don't necessarily get captured on the Vineland. And I do want to note that this version of the Vineland doesn't allow raters to give partial credit. So we did have to make some tough decisions about what a behavior, where that would fall. So we wanted to kind of share some of those examples. So for example, applying expressive and receptive, mostly expressive communication questions to children who are nonverbal, primarily using a communication device. That was something we had to think critically and creatively about. And then oftentimes there were layers to that. Parents, if we were asking about stringing together multiple words, parents would say, well, their communication device has words clustered together. So they'll hit one button and that'll have 3 words in it. Does that count? And that's when I would say, that's such a great question. I'm going to bring that to Thursday meeting. I'm not exactly sure how to score that. And another example, it also in expressive communication were unique gestures or signs that particular child would do and do with some consistency, that the parent and caretakers and family members knew what that sign meant. Like perhaps it meant food or sleep or was referring to a family member. But if the child wouldn't, if someone they weren't as familiar with were seeing that sign and wouldn't know what it was, how do we score that for communication? There were other considerations in terms of visual impairments. So one of the kind of early questions we ask is, if you have your child's attention and then point or gesture towards something and look towards something, will your child follow your gaze and follow and look at what you're attending to? And parents whose children had visual impairment would say, well, it really depends. I have to be in a specific range or place in their field of vision for them to do that. So it really depends how close someone is to their face, if they'll do that or not do that. And I was just consistently always so impressed by how parents would describe the context clues that they were using to understand and interpret their child's behavior. So parents would have such wonderful insight into what a behavior meant and how their child was trying to communicate. So how do we map that on to these questions that might not necessarily consider that or capture that? So these are just a few examples of the many, many weekly conversations we had. If anyone else wants to chime in with examples, please do, because this really was every week what a significant amount of our meeting was about. And it was really came from you all, came from parents really challenging us in our interviews and asking such thoughtful questions. That gave us really rich data. And now I'm seeing some chat. Our kids are so good at adapting, and we are also pretty good at reading. Yes, remarkably. It's really a beautiful, unique communication that is unfortunately not wonderfully captured and hard to explain and to describe in these standardized measures. And yet they are such vital ways that you are in fact communicating with each other. So trying to figure out how to measure that is so critical. Were there any communicators that SCN2A kiddos are developing that are seen across the population and are unique? Ooh, that's a good question that I don't know if without kind of looking across the data and only kind of interviewing, we ended up kind of as interviewees usually interviewing the same chunk of parents and families. So it's hard to draw from my perspective, but if anyone else can speak to that question, please jump in.
Yeah, I'm not sure myself. I'd have to think about that.
Yeah, that's a great question.
Humor.
Oh, I'm trying to think if there's specific humor in the Vineland. That's such a good question of like, when I think there, or even like shared enjoyment in certain activities. I don't know how well Vineland questions capture that. They definitely get at play, but I'd say that's different than sharing an enjoyment, which is such an important way of communicating. But I love that everyone seems to agree that the farts are funny. So that's
and has such an impact on quality of life, right? It's such an adaptive behavior to have humor, right? And so, yeah, I don't think the Vineland does a good job with that, honestly.
Yeah.
And it's one of those things, like this is one of the challenges here. I actually think it does ask about humor, but as one of the really hard coping skills.
Well, yeah,
And
high
so
levels, high that we don't even get at. You're right. Yeah.
High that we don't get at, because this is a place where there's uneven development and we can see growth and appropriate humor use, but by being forced into the Vineland structure, we don't get that far, and we're missing this really important, like the contextual information. A standardized measure gives you good information and can help with clinical trial readiness, but it doesn't fully capture the richness of a human being.
An individual, exactly. Good point.
Yeah.
Yeah, so if there are no other questions about this, I'll hand it over to, I believe, Amanda, who's going to talk about reliability and why we asked you all to do the Vineland interview with us so many times.
And
Yes.
pardon me while I'm still trying to get for some reason, there we go. Wasn't responding.
Thank you. Yeah, I love that the title of the slide is why did we ask you to fill out some measures only 2 weeks apart? Because I feel like that was a very valid question that I was getting from a lot of parents. It's one I can certainly empathize with if I were on the other end of things. And the reason for this is that we really needed to know how reliable our measures were. And just as a reminder for those of you who didn't have this spiel while we were doing the interviews, but reliability is really about how well our measures are going to repeat if we're talking about test-retest reliability, for example. So we want to know that if we measure something one time and then we measure it again shortly after, we're going to get about the same information from those repeated measurements. And this is especially critical for something like a clinical trial. And for a clinical trial readiness study, what we really need to know is how adept our measures are at capturing change, right? If we repeat a measure a couple weeks later and there's a different set of scores for your child, we want to make sure that that's because something has changed for your child and not because the measure is not very reliable. It can be a lot of work to repeat measures the way that we did in this study, right? The Vineland was a lengthy interview and you all were so wonderful. Those of you who were selected to do this kind of reliability component, so wonderful about repeating them with us. But you can see why, that might not be your favorite thing, being asked the same questions so close together, but it's very important information. And one thing that we did learn in doing the Vineland with you all 2 weeks apart, having you repeat those lengthy, intensive surveys at that reliability time point, is that our measures are really reliable. We had some remarkably high reliability on the different subscales for the Vineland when we did this test-retest analysis. A lot of times you're really happy if you'll look at those numbers on the screen, just for reference, with something that's like 0.80 or 0.85, and you can see we've got almost like near perfect reliability, which was really exciting for most of these subscales. So we're pretty confident that if something changes now and we're administering a drug or trying a new therapy, that when we see change with the Vineland in this population or others, that we're going to know that change is due to the intervention and not due to the measure just doing whatever it feels like doing day to day. I'm ready for the next slide, Dr. Berg.
Working on it. Wait, it is
Okay.
not responding. Sorry. Bear with me. Come on.
Yes, thank you, Leah. It really is. It's a hefty
There.
task, but we're very willing, or very glad that you all were so willing and patient to do that with us. So the other kind of reliability that's relevant here that, we did end up capturing as part of this study was inter-rater reliability. The idea here, as it says on the slide, being that if two different people measure something and we're using the same instrument, we're doing it around the same time, we should get the same answer. So 20% of all of our interviews were reviewed by Dr. Anderson. We didn't know which ones would be reviewed, keeps us on our toes. But the idea here is that Dr. Anderson would listen to these same tapes, and that is why we all asked to record when we were doing these interviews, but would listen to these same tapes, listen to these same interviews, and then score independently and hopefully get the same scores as us. It's really important that there be this consistency because there's 4 of us doing interviews, at least at the time that I was on the team. And we really want to make sure that Ari giving an interview is the same as Casey doing it, is the same as Lindsay doing it, is the same as me doing it. We don't want, say, my interviews to just have a much, much higher expressive language score, because then we're not really capturing what we think we're capturing. So it's sort of the idea that many of us are going to be operating as one. And it is a huge part of what our team did. We ended up having great inter-rater reliability, in no small part due to these weekly meetings that we were having with Dr. Anderson, with Dr. Berg, because we could all come together and talk about questions where the Vineland just felt a little funky as an instrument for the children in our study and the adults in our study. Like, we weren't quite sure how that item matched up to the things that people were actually experiencing. And, you know, spending that time every week and getting really great supervision from Dr. Anderson, we were able to come together as a team and get some very good inter-rater reliability, so that, you know, like Leah said, the data is as meaningful as it can possibly be, so we can stay consistent. And with that, I'm going to hand things off to Dr. Erin Katt, who's also one of the masterminds behind the science we're doing here, and knows quite a lot about why this reliability piece matters.
Thank you, and thank you all for listening to us talk about what we found and for volunteering for this study. As I was thinking about this, like, why did we have you fill this out repeatedly over a year? What are we going to do with it? I kept thinking about the FDA and thinking of this as clinical trial readiness. And should this slide go at the beginning of the talk of why are we doing this in the first place? But I actually think putting it more towards the end makes sense, because this is the seed and the investment for really great things. The FDA has very strict rules about what they allow, and we've been focusing on outcome measures and making sure that when we give a measure more than once, it gives you the same thing. And for that reason, we focused on the Vineland. On one of those slides, though, you saw that we also measured test-retest reliability for some of the other questionnaires that you filled out online, just to make sure that they gave us the same result, and they did. The FDA also is really interested in how do we classify participants in a study before they get the drug or the treatment or things like that. And then throughout the course of a study, are these outcomes that matter to patients? And so with this new focus on patient-focused drug development, they want things to matter to the stakeholders and the communities that are involved. And with that comes this checklist of things you need to knock off and say, yes, we did this. Yes, we did this. Yes, we did this. And reliability and validity is one of them in the short term. And then that leads us to say, if there's changes over a longer period of time, it's because the treatment, whatever the study is doing, is having an effect, and it's not just random. And then also knowing this is how the course, the natural history of condition happens over time. So are we changing the pattern through this treatment? Not just, is this the natural growth? So we wanted to make sure that we're getting reliable data, that we're getting data on domains that matter, that are paired with things that are important to the stakeholders. And really that's what the SCN2A Family Foundation is all about. Like that this is you're the ones that are telling us what's important. And then can we see whether those changes over time, what's the natural history, and preparing for future drug studies that are actually going to try to change that. There is future work, and that's why I say this slide makes sense here rather than at the beginning, because this is really just the start. There's a lot of rich data that we haven't and we will be looking at along the way, and we will be looking at how acquiring skills happens over time and what can happen to change, or like what kind of changes we expect and trajectories and moving them. So, and I see Leah, you threw something. Do I think that test, retest, etc. will come in value for publications? There will certainly be publications coming out of this, yes. But there is actually a drug study that got posted on clinicaltrials.gov in February of this year that is using the Vineland 3 and SCN2A. Like, when this gets published, there is no reason the drug company wouldn't come in and say, hey, can we see what you did? Because that you checked the FDA box that we have to check. And so you kind of did our work. So like that there is definitely places where we've well positioned future clinical trials to come in and say, hey, you've done the legwork to say the Vineland looks like a measure we can use, and not the Vineland as a whole, but specific areas. And the ones that matter, the ones that are highly reliable and likely to change, and things like that. So yes, I think that this has a really high potential for clinical trials to come in and say, you've done the legwork for us, not just with the Vineland, but with some of the other measures you filled out for who should be eligible. Where should we start? Can we stratify patients or study participants by their by some of the other scales and functioning levels that we've used? And does that matter for prognosis in the course of a trial? So I think that there's really a great strength in the data that we have here.
Fantastic. If I can, I think Erin said it all. We have a lot of work to do. And my last slide was to say thank you to everyone, and do you have questions? But everyone's asking questions. So I think what I'll do is stop sharing so we can all see each other and just let the conversation continue.
I'm in awe. I'm just so excited and I'm so happy. And I'm like, Erin, I wrote down what you said, because if it's okay, I'm going to use that in my talk on Tuesday. Because that is exactly what we expected and hoped would come from this. But you guys made it happen. I'm just over the moon.
Well, I give you a lot of credit, Leah. You really organized the community, and then the families who did this. And we're so grateful to all of you. And we are very cognizant of the fact that your lives are pretty difficult. You've got sort of landmines and crises going off around you. And you took the time and dedicated it to helping with this project. So thank you to all of you.
I know a couple questions that, sorry, my dogs are barking, that might come up in our community and they have already come up in our community as they were looking at their reports, was, should I share this with my IEP team? You know, will this help at school? And I don't know the answer to that. I know what you said in the beginning, that this is research and, but could it help at all?
I don't think there's any reason not to share it, with the caveat of how it was done and what the, so the kids, they could see that, especially looking at like growth value scales or growth scale values. I always mix that up, but especially looking at those scores and how those might change over time. And yeah, I'll let you speak to that maybe a little bit more, but I do not have concerns about how they share. It's their information. This is their property. This belongs to them. This belongs to you guys, right? If you can share it, if right? You can share with, as long as it's sort of clear that, it wasn't a clinical evaluation done by, and it's, as long as that's clear.
Yeah, no, I completely agree. And the report is written with that caveat in it. So that is made quite clear. Should not be a problem. We're hoping, I didn't mention it, but we are, will be mostly me, to update the infographic on the website that we did partway through the study. It doesn't include the Vineland, just a lot of the other information. And if you have any thoughts about what you'd really like to see in that, please let me know and tell others, you know, or we can take special requests.
Can I go back to that Vineland question for a second?
Oh, yeah.
Sharing it with schools. One thing that I will say about sharing these results with schools is the Vineland 2 did not have growth scale values. And so schools sometimes use the Vineland more as a parent checklist than as an interview. The interview is better for research purposes and for clinical trials. The survey one is really helpful for schools where it's meant to be faster, but if they've been using the Vineland 2, they may not know about this, the growth scales, but the growth scales are built for within person tracking over time. So they might even, like, this might serve as one data point, but if you want to see tracking how it changes, they might not even know to look for the growth scale. And so this is a place where I'm sure that you have done many times before, educated the people who are supposed to be educating you. You can do so again. Schools are very familiar with this type of scoring metric, and so like it's a personability score. There's a lot of math behind it, but they have these for reading, they have these for math. The schools are familiar with them, but if they don't know a test has it, they may not think to even look at it. And so this, like, if you do choose to share with the schools, maybe make sure that they know that the growth scales are the same thing that the students get RIT levels for their reading and math and or whatever, and that this is useful for tracking change over time, because that's what it's built for, and that's what the school wants to know too.
Yeah, that's a, oh, I was just gonna say that's a really important point, and I'm glad you mentioned the Vineland 2, because there's evidence that the scores on the Vineland 2 are somewhat higher than on the Vineland 3, particularly at the lowest end. So if they have Vineland 2s, they may look higher than the standardized scores on the Vineland 3. And I think a large part of that has to do with, I forget who mentioned it, but I think Lindsay, you did the partial credit. So in the past, if a child couldn't put on a shirt by himself, but could partially put it on with help, the child would get partial credit. Today, to get partial credit, you have to be able to do the whole task. Like you have to be able to make your whole bed, but maybe you don't do it every day, so you only get partial credit. So there's a little bit of a difference in the score there. So just be aware of that.
Great points, both of those. Yeah, I think those are really important. Thank you for adding those.
Great. And any other points to bring up? No, well, it's really, we're not done obviously, but it has been just such a pleasure and an honor working with this team and working with the foundation. And Jerry, you're valiant to stay up with us. Thank you. We wouldn't be able to do it without you.
Wonderful. Well, thank you all so much for this. This was an extra step that you didn't have to do, and you did it anyways, explaining the results that you so carefully put together for each of our participants. It's really meaningful, and we're going to share the recording with the community. I hope you have a great rest of your week and weekend.
Okay. Thank you.